Hello, my name is Feroz Mahmood. I am a professor at Harvard Medical School and director of cardiac anesthesia at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. I'm going to be talking to you about point of care ultrasound, its applications in education and competence. I have no relevant financial disclosures that are relevant to this talk. So the outline of the talk is we'll talk about the ultrasound's current status, the challenges of introduction of a new technology, the scope of expertise of anesthesiologists, the various educational initiatives to address this gap in education, should we go for certification or proficiency, and then we'll have the conclusion. So let's go over the current state of ultrasound in the perioperative arena. So introduction of ultrasound in the clinical arena has had a paradigm shift in the perioperative clinical care of patients undergoing surgery either under general anesthesia or under regional anesthesia. What anesthesiologists used to be just mere observers and service providers. But as a result of the introduction of perioperative ultrasound into clinical practice, their role has been redefined from observers and mere service providers to part of the decision-making process and part of the decision-making team. So we've had a significant change in our status in the perioperative arena. So the question of whether introduction of ultrasound in the perioperative arena is a challenge or an opportunity really depends on your perspective, which means if you are facile and competent in the use of ultrasound in the perioperative arena, then it is a huge opportunity for growth. However, if you do not know how to use ultrasound, then it is a problem, and you stand the risk of being disenfranchised from a clinical revolution that is happening with the introduction of this technology. And the most significant impact of the introduction of ultrasound in the perioperative arena is the way we conduct our clinical examination. We used to palpate and depend on our tactile sensation to diagnose abnormalities, anatomical abnormalities. Then we began auscultating, and that became a pretty significantly advanced art and science. And now with the use of ultrasound, we have begun to visualize physiology with an anatomical perspective. So this is a paradigm shift in the way in which we examine patients nowadays. And what has brought about this change is purely science, and that the size of the ultrasound machines has significantly reduced to becoming handheld ultrasounds without any significant compromise on their computational power. And as a matter of fact, contrary to what people would assume with miniaturization, their performance has significantly become better and advanced. And as a result of this miniaturization and increase in the computational power and performance, the perioperative uses of ultrasound transcend specialty lines, emergency medicine, nursing, interventional cardiology, vascular surgery, and a host of specialties use ultrasound in the perioperative arena, which goes way beyond the manner in which anesthesiologists use perioperative ultrasound. Specific to anesthesiologists, the perioperative uses of ultrasound span either as a diagnostic tool, as a monitoring modality, and a procedural adjunct, and then there are evolving indications. And for diagnosis, we use transthoracic and transesophageal, abdominal, chest wall. Monitoring, we use transthoracic and transesophageal, and we all know the procedural adjunct role of ultrasound for vascular access and regional anesthesia. However, the practice of ultrasound by anesthesiologists is purely silos based. That's very unfortunate. That's because regional ultrasound is practiced at a very high level for very subspecialty applications of anesthesia for regional pain, intensive care, cardiac, but there's no significant crossover, which means acquisition of skills in one specialty does not necessarily translate into the others, despite having similar physical principles, similar workflow, and similar understanding of science of ultrasound as is for any other specialty. But we really do not have any cross-pollination of those proficiency from one to the other. And therefore, despite having a cycle of waves being transmitted and then reflected in the analysis, there are applications of ultrasound with very little crossover of talents and crossover proficiency. And the range of the expertise or the range of comfort level of anesthesiologists with perioperative ultrasound ranges from novice to advanced beginner, competent, proficient, and a very minority of people who are expert in the use of either one of them. Now, this brings us, what are the challenges of a new technology when it is introduced halfway between your practice when you're already trained and a practicing anesthesiologist or a practicing physician, and a technology which completely changes the way we monitor patients is introduced into the clinical practice? Well, like any other innovation, this is disruptive. It's unpredictable, and often precedes regulations that govern how this technology is applied and practiced in the clinical arena. And the dilemma is that innovations always precede legislation. Technology gets introduced and established prior to guidelines for its use are developed, and anesthesiology is not the first specialty to face this dilemma. So, robotic surgery, laparoscopic surgery, interventional cardiology, these are all specialties for which there's continued introduction of new technology into the clinical practice without any legislation, without any guidelines for the control of its use and its application. People have to do kind of an on-the-job training and on the run to increase the proficiency and comfort level with these technologies, and therefore this is not the first dilemma or the first time this dilemma has been introduced. And these are disruptive innovations which do not really care who knows about it and who doesn't know about it. And then the best way to harness change is to introduce it yourself and not be its victim. And the best way to predict the future, as I wrote in the editorial, is by creating it. So therefore, let's not be the victims of change, and let's drive this change. Is the simple lesson that we get from not just anesthesiology but multiple specialties that have faced this challenge. So how can we do that? There are two ways of introducing proficiency in clinical practice, and depends on what you really want to look for. Either you want to create experts or you want to create proficiency. Expertise is a top-down approach in which you establish a destination, that is certification, without defining a pathway to get there. So if they're experts, they'll gradually train people who will eventually become more proficient in it, and you are geared to create a class of experts for a trickle-down effect. On the other hand, is if you're looking for proficiency, then that's a bottoms-up approach, which means you develop pathways and training programs and practice pathways to introduce people to have a baseline knowledge of how this technology is practiced. Therefore, you're using something, a pathway to create a level of understanding and establishing readiness for clinical use of this technology rather than uh, expertise. One of the most fundamental examples of a bottoms-up approach is the introduction of FLS and FES programs, and they stand for Fundamentals of Laparoscopic Surgery and Fundamentals of Endoscopic Surgery. These are programs that were introduced to establish proficiency and not expertise. They're multimodal. These are practice pathways. They establish readiness and not expertise. And there was, when for practicing general surgeons, you really didn't have to establish a certification for laparoscopic surgery. You had to establish your readiness for its clinical use. And the top-down approach, one of the most important examples is in the field of National Board of Echocardiography, in which there was TE basic and advanced certifications were created. These were cognitive exams. There was no practice pathway. It establishes expertise and not proficiency, which means once you take the exam, you become certified in the use of transesophageal echocardiography by demonstrating some experience. But exactly this is what the top-down approach is. It's establishing a certain destination, that is certification or a testament status, and not telling people how to get there. And basic perioperative TE certification is a case in point. This is something which is a classic example of a top-down approach where we establish to a destination, that is a certification in basic perioperative transesophageal echocardiography, without telling people how to get that expertise. How do you cross all those stages of learning from a novice to an expert was not defined and was left to the people to figure it out for themselves. And therefore, it's not something that is or should be practiced or followed, at least for perioperative ultrasound, in my opinion. This is a opinion piece that I wrote with two former presidents of the Society of Cardiovascular Anesthesiologists, and that's about our perspective on perioperative ultrasound training. The long and short of this opinion piece was that at this current moment in time, the way ultrasound is taught and practiced, it is considered a desirable skill. We are soon going to be at a stage when it is going to be an expectation, and there's a large body of anesthesiologists who are neither proficient or experts in the use of perioperative ultrasound, and we have to have some form of addressing and resolving this conflict. So therefore, in my opinion, the real problem for the widespread application of perioperative ultrasound is lack of proficiency, and the solution is practice pathways in the same line as fundamentals of laparoscopic surgery and fundamentals of endoscopic surgery. So what is the scope of expertise of anesthesiologists? Let's go over these things. For example, they are practicing anesthesiologists, they are in-training anesthesiologists, and they are medical students. So the needs of the medical students of today are being addressed, and they are being taught ultrasound at a very high level, even in their medical education. The real challenge is the practicing anesthesiologist, and in training anesthesiologists is the opportunity where we can define and we can test our pathways of education and training, and then extrapolate those pathways to the challenge group, and we can again train into the use of perioperative ultrasound. Preclinical medical education, like I said in the beginning, is being addressed at a very high level, and most medical schools in the United States have predefined and specific ultrasound curricula that the medical students are supposed to go through, and these medical students, when they come for clinical practice, are far better ultrasonographers than any one of us right now, because they learned it as a trade, just like use of stethoscope for auscultation. And to follow in the same line, the American Society of Echocardiography has come up with certain state-of-the-art medical education guidelines on the use of cardiac point-of-care ultrasound application in the clinical arena. And they have detailed, expectations, what to be done, the limits of this point of use of this ultrasound, and what encompasses proficiency in the use of point-of-care ultrasound. And this is a very welcome change, and because it's being addressed at a very high level, addressed scientifically, and addressed and it is addressing a needs assessment which exists right now in defining the curricula and the scope of practice. Again, another one which shows in year one, you're supposed to know sonographic anatomy, then you're supposed to know physiology, the disease block, and then finally the clinical skills. So it's a very methodical, algorithmic approach to developing proficiency in use of perioperative ultrasound. So in the same line, the Accreditation Council for Graduate Medical Education and the American Board of Anesthesiologists have recognized ultrasound-guided techniques as specific training milestones, and they are becoming part of the OSCE examination that the ABA conducts for establishing and conferring certification and certificates of diplomate certificates in the United States. So, as a result of that, American Board of Anesthesiologists has significantly increased ultrasound content in ABA-sponsored examinations, and the graduate medical education is also trying to introduce formal ultrasound education curricula during accredited anesthesia training. However, the graduate medical education has certain challenges because patients come to hospitals for clinical care, not education. It is time limited and there's pressure to perform. It is not graduated from simple to complex, and it's not non-integrative, which means what you see and learn are different. And therefore, introduction of a new technique to be taught within the same time frame in this entire, very busy and very time-specified training is indeed a real challenge. So, in this sense, what the programs have incorporated and what the innovations that the programs have introduced into this education is to create facilitated learners using multimodality education tools, simulators, hands-on training to reduce the orientation phase of the training and to have make every clinical encounter maximally educational. And that's the similar approach we use for ultrasound program for preclinical proficiency, which implies that our residents and our trainees should have the basic knowledge of the use of ultrasound in its very specialized applications so that they, when they go to regional, cardiac, vascular, they know exactly what to do because the basic principles of the application of ultrasound are the same. So a program that is supposed to infer preclinical proficiency has to be multimodal within the regulatory 80 hours of the week. It has to be integrative as far as content is concerned. It has to be graduated from simple to complex. Has to be frequency oriented, which means the first exposure followed by longitudinal exposure over the time. And it is an endpoint based, which means this preclinical training is not supposed to reduce your clinical training. It is only supposed to make it better. So when it comes to practicing anesthesiologists and the ultrasound education, it is a bigger challenge. It is widely practiced. There's no formalized curriculum. There's significant variation in exposure. And practicing anesthesiologists use ultrasound with on-the-job training and repetitive exposure. You just learn it from someone who's your friend, and then you just keep practicing and keep getting better without any formalized curriculum. So as far as the various aspects of use of perioperative ultrasound are concerned, there's a certification T offered by the National Board of Echocardiography. Point of care certification will be offered, and examinations are being concerned. There's no methodology or no pathway for anesthesiologists to become certified in transthoracic echocardiography, at least not by the National Board of Echocardiography, and regional users of ultrasound also do not have any certification. So now let's get to recognize and orient ourselves with the various educational initiatives that can be taken to introduce proficiency in the use of perioperative ultrasound. In Beth Israel Deaconess Medical Center in Boston, we've had a tradition of excellence in ultrasound and echocardiography education. We were the first medical center in the world to report use of TE and TT simulators for a formalized curriculum. It went on to develop a multimodal curriculum for training in transthoracic and transesophageal echocardiography. In 2015, we developed a Fundamentals of Ultrasound course for our residents, and gradually over the time, we have transformed this program to be introduced to faculty also for developing proficiency in ultrasound since 2017. And the comprehensive program for residents consists of a graduated, this is simple to complex, an integrative program, which is repetitive and has a significant component of deliberate practice. It is customized and training specific. It's interactive and being hands-on, and is geared to impart proficiency and not expertise. And we hope to impart proficiency in 3 specific uses of perioperative ultrasound, and that as a diagnostic tool, as a monitoring modality, and as a procedural adjunct. And since proficiency is a kind of a complex subject to define and to impart, we believe that cognitive knowledge, manual dexterity, and workflow understanding, which means those specific steps that you need to do to use your cognitive knowledge to demonstrate your manual dexterity, is a composite, and that is called proficiency. And that is the more important thing. So it's not merely cognitive knowledge, it's not merely manual dexterity, but also a significant understanding of workflow understanding of a specific procedure. We take, haptic task training with the simulators for transesophageal and transthoracic echo. We take instrument familiarity as a very important part of developing proficiency, which means even if you're very good at doing something, if you do not know how to operate the ultrasound system, then that's a useless skill. We teach residents and fellows the image orientation, and the most important thing is teaching them a detailed and a comprehensive equipment operation. So our current model of educational initiative for proficiency in perioperative ultrasound ensures participation and minimize attrition, which is a very important limitation in graduate medical education. So as a CA1 in the first year of anesthesia training, we have a concentrated exposure, and over the years through their second and third years, we have lectures blocks for a longitudinal program for introduction of proficiency. So in our, we had a fair grant on this one, and for the introduction of fundamentals of ultrasound and verification of proficiency. Our hypothesis was that it is feasible to establish the readiness of anesthesia residents for clinical performance of perioperative ultrasound through a multimodal fundamentals of ultrasound course designed for verification of proficiency. However, it's not just the residents, it's the faculty also. And lack of proficiency on part of the faculty has significant consequences, because you realize that trainees' exposure to any clinical procedure, any technology, is determined by faculty's proficiency in that procedure. There's a quality and safety of invasive procedures is improved when you use, ultrasound, and also fiscal consequences, because we can bill for these services because by making these procedures safer for the patients. So ideally, use of perioperative ultrasound should be ubiquitous to anesthesiologists and not an added proficiency. Anesthesiologists should be considered experts in perioperative ultrasonography, and therefore, having developed proficiency should obviate the need for any attempts to introduce any special certification. However, the problem in this situation is that the large number of practicing anesthesiologists are at the risk of being disenfranchised simply because of lack of proficiency in perioperative ultrasound. So the solutions are multiple. You have to have a personal initiative to teach yourself. You have to have departmental initiatives to facilitate your desire, and finally specialty initiatives to be recognized as the sole experts and the sole practitioners of perioperative ultrasound. For example, for a personal initiative, your education is your own responsibility. You have a personal commitment towards continued training. You should have a level of commitment for that. And ideally, you should be able to achieve this thing with minimal financial and logistic hardships. It should be goal-directed towards a specific endpoint. Departmental initiatives consist of recognizing the value of skill progression, recognize the value of proficiency in ultrasound for patient safety, quality of clinical care, and there should be mechanisms for recognizing expertise and credentialing, and finally, there should be some fiscal value to the department and the individual practitioners as well. Specialty initiatives consist of continuing medical education courses, recognition of the proficiency as a necessary skill set. These are political and societal initiatives. And a successful ultrasound for faculty should be a value-added proposition for the individual as well as the department. CME credits, improved care, fiscal benefits, improved education for residents, and improved patient safety. And workflow is a very important concept of this proficiency. We concentrate on manual dexterity and we concentrate on developing cognitive knowledge, but knowing the workflow, which involves those practical steps. Is it emergency? Is it elective? The patient intubated, sedated, any contraindications? Which machine, which probe, which knobs to use, how to optimize the image, and image acquisition and storage are all components of workflow which we need to be proficient at when we use ultrasound. And if for those people who ask, what is there any benefit in an outcome, or have you demonstrated any improved safety? This is one of those editorials by Dr. David A. Bates from Harvard School of Public Health, which essentially addresses the same thing that as in anesthesia as well as in aviation safety. We have made these small changes which are commonsensical and logical and not dependent, and we're not dependent on large randomized double-blind studies to improve our efficiency and improve our safety. And that's why we have achieved an incredible track record of safety by making commonsensical changes. If you are getting a central access with simply assuming anatomy, and the other fashion, you are actually looking at the anatomy in real time. It is just common sense. You do not need to have a study to prove this thing. Therefore, ultrasound proficiency for faculty as for residents is not only cognitive knowledge, manual dexterity, but also a detailed workflow understanding for that specific procedure. So this is an article that we published, I think about a year ago, which was basically on the introduction of the concept of workflow training for a clinical procedure. And with our simulators and task trainers becoming increasingly sophisticated, and with mixed haptic and augmented reality, it is very easy to achieve instrument familiarity, workflow understanding, and knobology even prior to doing an actual clinical procedure. So therefore, we have to decide at this stage, when the ultrasound in its infancy, I wouldn't say infancy, but a little bit more mature in its application in the perioperative arena, what is more important to us? Do we want to establish a certification, or that is a top-down approach, or do we want to establish proficiency and spread basic knowledge and tell people how to get there? So to make it very simple, competence is the path, is certification your eventual destination. Competence is what you're looking for, and proficiency is the pathway from competence to certification. It has to be methodical. You cannot start at certification and come back to competence. And lastly, I would like to tell people that it is indeed a stressor on our professional lives to introduce and to become more comfortable with a new technology that has been introduced that we were not trained for when we were undergoing accredited residency training. And in essence, don't really get better by chance. You get better by change. Thank you.